All right, well, welcome everybody. To our final developmental disability rounds of 2017. Welcome, Dr. McDoom in particular. So today we have a couple of guests, in particular, Dr. Richard from the hospital has joined us. And we're going to talk about a patient who Joan and I have been seeing for many, many years. And in fact, Mandy Harloff, who was at the time Mandy Soltis, saw him even before we did. So this is many, many years ago. Well, not that many. I don't want to make her sound very old, but and what I find fascinating about him is that his language is terrible, but the really question on mine is it his language or is it his thinking that is disorganized? And how do we distinguish those things? And in particular, I think the reason we asked Dr. Richard to come was because schizophrenia is where these things in particular tend to intersect around the idea of disorganized thought, speech, and thought disorder. So, which direction am I supposed to be going? There you go. Okay. So what am I doing? Okay, good. All right. All right. So there's our title. I have not had any significant financial interest, and I don't believe anybody else has either, Julie. All right. Okay. So this is where the question came up. So prior to DSM-4, one of the criteria for schizophrenia was what they called a thought disorder. And it was changed in DSM-4 because for a variety of reasons. One, psychiatric diagnoses are meant to be based on observable behaviors. We cannot observe people's thinking. We can only observe their speech. And one of the reasons also was that the diagnosis of thought disorder is a fairly circular thing because thought disorder is based upon, or we infer that from disorganized speech, and based upon the disorganized speech, we then assume people have disordered thought. But it really is a very circular argument and not really a good one. But I think the question still remains in people with schizophrenia, is it their thinking that is disorganized or is it their speech that is disorganized? So we're going to present a case, which Joan finds amusing, of a young man named Fred Duff. So, and this, we've seen him for many, many years, as I said, but this will start earlier this year. So he's 15 years old. He attends high school in a segregated developmental class. He lives with his parents and his older sister. And his mom had called asking for an urgent appointment because he had attacked his sister. I think what had happened was he was sitting at home. His sister said he was an idiot or called him something because he was doing something. And he became really aggressive. He actually attacked her. I think he punched her in the face a few times. And I think he scratched her fairly significantly. As we'll see later on, his language is so disorganized that even asking him what happened with his sister, he really wasn't able to convey any sort of information about what had happened and why it had happened. So if we go back, so he was diagnosed with autism at the age of 6 or 7. Cognitive testing at the time, I actually made up the number 12th percentile, so it's not correct, but it was approximately correct. So I think really it would have been, I don't want to say impossible to do verbal IQ, but exceptionally difficult. But his nonverbal intelligence was certainly not within the disabled range anyway. He's always had problems communicating with speech. So he has, I was just looking back to his chart today. So even going back to 10 years, when he was 7 or 8 years old, he had problems with pronoun reversal, delayed echolalia, things like that. And as well, a long history of ritualistic behavior. So in elementary school, he would, if he said hello to people, he was insistent that they say hi back to him. In the boys' washroom, he'd walk in and want to give everybody high fives, which probably created a lot of discomfort among teenage boys in the washroom and actually upset a number of people as well. But again, if they didn't give him a high five back, he became quite agitated about that. I first became concerned about him, or quite concerned, when he was in grade 8. So all of a sudden, he developed really dramatically worse ritualistic behavior, and ritualistic in a way that might be consistent with autism. So he would spend hours checking, or not hours, he spent a lot of time every day checking the toothpaste cap to make sure that the cap was on just right. So he would untighten it and then tighten it and then loosen it and tighten it. Everything had to be in the dishwasher. So he would wake up in the middle of the night and go into his parents' room and ask them if they were finished with their mugs that they had been using before they went to bed, and wake them up and then put it in the dishwasher. If anything, so if there was food in a container, so if there was, the example his mom gave me that they had bought 6 muffins in a container, once that container was open, they could not put it back in the fridge. They had to eat all the muffins. And so that led to a fair amount of food wastage because he got very agitated if they tried to put the food back in the fridge at that point. And then in the summer, prior to grade 9, he looked terrible, frankly. So he came in, and I saw him, and he was more disheveled than usual. He was mumbling to himself. There was something really wrong with him in a way that I had never before seen him. So I asked Joan to see him again. I think she had seen him previously, and I asked her to see him again because even his communication seemed worse. And then a couple of months later, he seemed back to his old self. So I don't know whether it was the language testing or Joan that helped him, or just the natural progression of his problems. But it certainly resolved. But I was really concerned with him at that point. So in high school, he continued to have difficulties with ritualistic behavior. So again, he insisted people say hello to him. There was a girl in his class who was nonverbal, and he frequently became quite agitated with her because he would say hello to her and she would say nothing back, and he got very upset. He insisted upon all drawers having to be closed. Even students, if they had desks with drawers, he wanted them closed. He told me, his mom told me the story once where he had been walking by a classroom. I'm not sure why he was walking in the hall alone. He was walking in a classroom, and he noticed that one of the teachers who was up in front of the class teaching had left a couple of drawers to their desk open. So in the middle of the class, he walked in, closed the drawers, and then walked back out again. And I've always wished I could go back and just watch the reaction on the teacher's face, have some unknown student walk in, close the drawers, and then walk back out again. And the other things continued as well. So at home with the toothpaste cap and the mugs and things like that. And if he wasn't able to complete rituals, at times he became pretty aggressive. So he would grab people by the arm, he would yell at them. And it was a real concern for his mom as he got bigger. So we started him on risperidone because of the agitation, and there was some improvement, although the ritualistic behavior really didn't change at all. And he was involved with program at Thames Valley Children's Center. I think some of our behavior consultants here were involved as well. There really wasn't a lot of improvement in the ritualistic behavior at all. That his agitation around not doing the rituals improved, but not so much the ritualistic behavior itself. In a somewhat surprising turn of events, I guess, a friend at church suggested that they try sertraline and actually wrote a prescription for it for them. It didn't help, it may have worsened the behavior, and so then this friend at church then suggested they try clonazepam and wrote a prescription for that as well. I don't know if they billed OHIP for that time also, but it seems fairly inappropriate, frankly. And around this time, he also began to urinate multiple times per hour. So I was just reading a note from school when he was in grade 9, and they said every 70-minute period, he probably got up and went to the bathroom 5 or 6 times. And he saw a urologist, I think, and a nephrologist, and they said they could find no evidence of any problems with his kidneys or his bladder. He didn't have diabetes, so there was clearly something going on. And really, I think it was just more ritualistic behavior. And in the last year or so, cognitive testing has been repeated as well. That overall, I don't think his functioning has deteriorated as he's gotten older, but I think his ability to communicate may have, or it may have been just that he hasn't kept up with expectations. It's hard to say. But at times, when I say he speaks coherently, I meant that his articulation is fine. He has no problems with it. But when he speaks, at times it is impossible to understand what he says. So I'd say this episode with his sister, where he was trying to describe what had happened, if I didn't know what had happened, there's no way he would ever be able to describe it. It's a fairly simple thing. My sister called me an idiot, I scratched her or I hit her. He couldn't do that. There have been a few episodes at school where he had given a chocolate to his teacher, and I'm not exactly sure what happened. But even with that, when it happened, he couldn't tell me about it. So we look at different kinds of things that have been described in the past as thought disorder. So he certainly is tangential. He gets off topic. He answers off topic, but also has derailment. So as he's talking, he gets further and further away from the goal of what he was saying. He perseverates exceptionally. So we saw him a few weeks ago with Dr. Richard, and there had been some issue with his grandmother. I think basically he would call his grandmother over and over again every day to ask her what she was doing and if she was okay, or to tell her things. And I think during the hour that we saw him, he must have brought that up 5 or 6 different times about what he was going to do with her, or what he was supposed to do. He uses neologisms, so he makes up his own word. One was Renopian, which I don't know what it means. And when we asked him recently, he said he didn't either. And he also really has poverty of content of speech. So he says a lot, but there's very little detail or content. And frankly, as I say, at times it's incoherent. It's almost as though the sentences have nothing to do with each other at times. And we are going to have a little play in a minute that Sarah said she wanted to practice her acting chops to sort of demonstrate that. But anyway, so his past medical history, he is a very healthy young man. He's never had any hospitalizations. There's no operations, no seizures. He doesn't have any allergies. When he first developed the obsessive compulsive symptoms, his mom wondered whether or not he had pandas, which is secondary to strep infections. He doesn't. All of his organs are working fine. So there is something called anti-NMDA encephalitis, where people get antibodies to a certain receptor in the brain. He does not have that. He has an EEG, which is normal. His Fragile X testing was normal. He does, however, have a deletion on chromosome 7q, and I think that's in the area of actually FOXP2, because I think that was reported at one point. And the reason that that's interesting is his mother has the exact same deletion, so he inherited it from her, and she is quite vague when she speaks also. So in talking with her, when we started him on the risperidone initially, they came back afterwards, and she was talking about a bunch of things, and I thought she was actually saying that it made things worse, and that he was having a lot of side effects, and so I said, okay, so it sounds like we need to really probably reduce that and look at a different medicine. He said, no, we want to keep it. He's doing great. And I had actually had the impression she was saying the exact opposite. Sometimes when I meet with her, I almost want to say to her, okay, just yes and no other words at all, please, because I can't follow what you're saying. So when we saw him recently, sort of back earlier in the year, so, he appears at stated age, he's appropriately dressed, he's groomed, he doesn't have any abnormal movements, there's no evidence of side effects from the medicine. As soon as he walked into my office, he would immediately, and this has been going on for several years now, he walks over, and I actually intentionally leave the drawers open to see what he's going to do, and he always walks in and closes them. Sure, by all means, anybody's welcome. He greeted people in the room, so he walked in, and when we saw him with Julie a few weeks ago, he actually came in and sort of walked up to everybody and introduced himself and shook hands, made good eye contact. At that point anyway, he sat throughout the interview, so he wasn't all over the place. He uses a wide range of gestures and vocal expression as well as facial expression. However, it's exceptionally difficult to understand him, so he wasn't able to describe this incident with his sister. He had lots of evidence of disorganized speech or thought disorder. He referred to himself as he or as Fred. And when we were talking with his mother, he played Fruit Ninja, which is the exact same game he's played at every appointment for the last 5 years, I think. So, and I'm not actually sure he knows how to play it just watching him. But so Sarah and I are going to act out what the conversation might have sounded like, if I can find my. There it is. All right. Scene.
So I'm Rob in this.
Yes.
What happened with your sister?
Well, it's kind of strange.
You're not typically aggressive, are you?
I'm not aggressive. I'm not too aggressive. Aggressive because if I get too aggressive, well, my mom, she started screaming at me. Like I started interrupting. I started repeating. I started like repeating. Because like, it's very like too hiring, Dr. Nicolson. It's like we're getting very tired, Dr. Nicolson.
You're getting very tired of what? The repeating?
The repeating, because you know what, Dr. Nicolson, it's like it's very domestic, automatic. It sounds like too difficult.
What's too difficult, Fred?
If it's too like of our brain insulting to very aggressive, because you know what, Dr. Nicolson, that's it. It's very like, that's very sad, because when I told my mom and dad about using those charts, I won't go to bed, it's very like too difficult. I threw up. I got sick before. It's very like retiring, Dr. Nicolson. If it's too hard, if it's too aggressive, like when I try to see all those students, like if I don't go to high school, like to earn a job, like if Fred was to ask Mr. McGillicuddy the same question, like he wants to ask the same question, and my mom wants to ask Mr. McGillicuddy about running inside school, because my mom was screaming at me, started yelling at me, Dr. Nicolson. Like, what am I going to do with her?
Why was she upset? Because you were running in the school?
I was running in the school because, what's his name again? Foddy.
What's his name?
Foddy. You know why? Because he started taking the cookie away. That wasn't very nice, Dr. Nicolson. It's very like too aggressive, Dr. Nicolson. And so that is actually transcribed verbatim from an appointment earlier, or part of an appointment earlier this year. And so you can see that, and that was basically his question was, what happened with your sister? And there's nothing there at all. So, I mean, he is profoundly disabled by his language/thought problems. So in terms of his diagnosis, he remains a real puzzle to me. So he has a diagnosis of autism, and I'm not sure it's incorrect, but I'm not sure it's correct either. So he certainly doesn't have any he doesn't have any appropriate peer relationships. He has ritualistic behavior. He has unusual speech patterns. But he introduces himself appropriately to people. Now he may have learned that. And in talking to him, I think he tries to engage in appropriate conversation, because he stops, he will answer things. In talking to him, I almost get the sense like he's talking to me in a foreign language, but doesn't know that I don't understand what he's saying, because he doesn't look as though he gets it, that other people have no idea what he's talking about. So he's been diagnosed with a language problem, and it's the question: is it really a language problem? That on paper, clearly his language is very disordered. I think you'd wonder certainly with somebody with that kind of thought disorder, is it schizophrenia? But there's no evidence of hallucinations or delusions. But I'm not sure you'd know if he had hallucinations or delusions, frankly, other than behavior. But he's also really hasn't had a significant deterioration in his functioning over the last few years either. And certainly he functions at a very low level overall in terms of adaptive functioning, but I don't think his nonverbal intelligence is exactly consistent with the diagnosis of an intellectual disability either. So as I say, have no idea what is actually wrong with it. That might be the wrong word. I don't know what his appropriate diagnosis is. So just for me to wrap up, so a follow-up, because I don't know what's going on, I thought a trial of methylphenidate might help, right? Can't hurt, might help. And his mom actually said when he came back after a couple of months of being on bifenthrin that he was actually doing somewhat better. She said he seemed calmer, there was perhaps less perseveration. At school, they had noticed some improvement. At the last time we saw him, he actually walked in and asked me if he could close the drawers before he closed them. As he was talking, he referred to himself as Fred at one point, and he actually stopped himself and corrected himself and said I, which he hadn't done in the past. So I wonder if his thoughts are a little bit more, or his language are a bit more organized, but it's really difficult to say. So any questions about him? And then we will move on to Dr. Gardner's presentation.
I'm not a Dr. Gardiner.
Sure you are.
Yeah, no.
Yes, Dr. McComb.
From the sounds of it, it seems he's really functioning.
I don't know if it is though. I think is he worse on language testing?
Well, you're kind of stealing my thunder here.
Okay, so sorry, don't come back. I'm not sure he is. I mean, he goes to school, he does his work, he's not a behavior problem there. He's certainly not keeping up with expectations, but that's because I think everybody else is expected to be improving at the same time. So I don't know if he's actually deteriorated. I don't think he's not, I mean, his hygiene is fine. When you look at him, he looks well put. If you just saw a picture of him, he looks fine. And I don't know if he actually is deteriorating. I mean, that's a question in my mind, but I'm not sure.
That was only one incident where you saw him trouble.
It was the one time only, and he was mumbling to himself, and literally 2 months later, he was back to his old self. I don't know what happened that day, and I never will. It's unfortunate that we can't do sort of emergency blood work or MRIs or something like that to see really what was happening with him at that point in time, because that's why I had asked Joan to see him specifically, and it was in the summer because he presented in such a different way that I had ever seen him before, but he's never been that bad again.
And by the time I saw him.
Pardon me?
It took a couple of months though.
Well, I don't know. I only saw him once in those 2 months, so it might have been the next day. I have no idea when he improved. You know? Yeah, Kathy.
Yes.
Only when he had to wake up to get his parents' mugs and things to put them in the dishwasher. Other than that, no. His sleep was otherwise fine. Never been a problem, really. Yep, Ben?
I was thinking of the term schizophrenia, PROPS,
Yep.
which is schizophrenia on top of intellectual disability,
But his nonverbal intelligence is not within a disabled range.
nonverbal.
He is nonverbal. I mean, verbal intelligence, I don't even, well, when we saw him last time, we actually tried to do a couple of the nonverbal measures from the WIPSI, which is for children. And I was actually surprised that he could do a few of the similarities, the very basic ones. But I didn't even think his language would allow him to answer, how are a dog and a cat the same? And he actually answered them better than I would have expected. Now the WIPSI is meant for children up to 6.5, so it's not a huge demand on him. But I actually didn't even think he could do that. But as Joan will tell you in a minute, I mean, his nonverbal intelligence is not, I don't think, within the disabled range. As well, it's not good, that's for sure. Yep.
What about his hyperrelation? Significance?
They're all, aren't they? I think they're all variants of uncertain significance. Yeah, they are. So I mean, there has somewhere on 7q there is an area that's been associated with autism. I think it's like 7q28 or something like that. I don't know exactly, but I think when they do the follow-up FISH testing, I think they used FOXP2 as a reference, which is a gene that's initially they thought it was associated with language problems. My understanding is it's actually more associated with oral motor problems. But and that's the question in my mind. So his mom is really vague, as I say, and she has the same deletion. So is that related, or is that just an incidental finding? And I don't know the answer to that. But yeah, no, they said it was a variant of uncertainty as well. Okay, so I will turn it over to Ms. Gardiner, and she will wow us.
I think you're just trying to get me in trouble with the college.
Oh yes, that's right.
Yeah, we can't call ourselves
doctors.
doctors.
Even people who have doctorates cannot call themselves doctors.
That's right. That's right. Okay, so I will just give you some information from the language perspective about Fred, because he is an interesting kiddo, and like Dr. Nicolson said, he's actually been followed by speech language pathology services for a very long time. That in early primary grades at school, he was known to the school board speech language pathology service. And then he has been followed by the speech language pathology component of the ASD program for several years here as well. So just to set the stage with a little bit of context. So in the DSM-5, under the heading of communication disorders, there are 5 different subtypes, language disorder being one of those, and that's the one that we're going to explore a little bit in terms of Fred. I think there are a couple other that we could potentially consider in relation to his profile, but the question of language is the one that we've really looked at over the years, so that's what we'll talk about now. So just for anybody who's not familiar with the DSM-5, in terms of looking at criteria for language disorder is defined by having persistent difficulties in acquiring and using language, and that would be across different modalities, so receptive, expressive, spoken, listening, written communication, due to either deficits in the comprehension or understanding of language or the use of language, and that would be affecting the vocabulary skills, so word knowledge, understanding, and being able to find the right words to be able to express oneself, grammatical abilities, so understanding that the rules of grammar and the components of grammar, like plurals and verb tenses, have meaning represented within them, and that those little bits are important to conveying a message. And impairments in what we call discourse or conversation, or using language for more extended purposes, so beyond the word and the sentence level, but really the practical full use of language in day-to-day life. And in the DSM-5 as well, what we would say is that a language disorder is present when language abilities are, and they use the word substantially and quantifiably below those expected for age, resulting in functional limitations. So what's interesting about the DSM-5 is that there's not an actual number that we use to define what is quantifiably and substantially below, and so it's an area of a little bit of subjectivity, but I think the significant part of that component of the DSM-5, again, is the functional limitations, how much that's really getting in the way of effective communication. And when it talks about effective communication, again, it's looking at academic use of language, being able to use language to learn, being able to use language for social opportunities, and quite frankly, just being able to use language to navigate the activities of daily life, getting where you need to get and participating the way you need to do that. The onset of symptoms for language disorder is within the early developmental period, so early childhood, and we would say that a language disorder is defined by being, language difficulties that wouldn't be explained by an alternative diagnosis, so not because of hearing impairments or, syndromes, other things like that.
Why not due to other syndromes? Because if people have a language disorder, they have a language disorder. So let's if I can be argumentative.
What I know of you.
So this young man, clearly there's something wrong with the way his brain works.
Mm-hmm.
So we can say he has a neurological problem.
Yes.
So does that rule out a language disorder?
Well, I think that's the question to be decided, right? So when we're looking at language, there's really 2 sides to language. So there's expressive language, which is the way one uses words and sentences and all those little grammatical bits to convey their thoughts and ideas to other people. The flip side of that being receptive language, which is how we understand the words, sentences, and grammatical bits that other people use to share information with us. It's interesting, in the DSM-4 text revision, they separated language disorder into different subtypes. So there was what they called expressive language disorder, which really prioritized the impairments in being able to express one's thoughts and ideas to others. But receptive language was considered to be intact. Or there was a mixed receptive and expressive language disorder in which both domains were considered to be impaired. In the DSM-5, they've gotten rid of those subtypes, and I think it lumps everything together in a way that sometimes it's a little bit more vague to think about what's going on, but it is what it is, and so that's just the components of language that we want to be thinking about. So this part's a little bit redundant to the first slide I showed you, but really it's just summarizing again that a language disorder is really looking at impairments in those, what we would call those core level skills. So the vocabulary, word knowledge, and the grammatical rules of language that we use to construct sentences and to combine sentences to share information. And what that means is if you don't have good building blocks, then you're not going to be able to use language functionally for those higher level, more day-to-day language needs for things like discourse, conversation, storytelling, thinking, reasoning, navigating the world. We would know that we are looking at concerns about a language disorder, again, if those first words are starting to be delayed. So I think for Fred, even, like I said, he was involved with speech and language services right from the get-go in terms of school. People were recognizing early there were delays in his word knowledge, and his speaking was behind where it was supposed to be. Did he do there you go. So type talk early on. Sentences are simple, they're late to come, they tend to not have the grammatical components that we would expect them to have at the age at which we would expect them to have, and therefore, again, the skills that would lead from those are compromised as well. To look at a diagnosis and making a diagnosis of language disorder, again, we've kind of got that funny term like we talked about earlier of substantially and quantifiably below expected for the age, and we would gather information about that from 3 different sources. So one would be that we look at that case history and development and looking at those early markers for the potential for a language disorder. Were words delayed? Were there fewer words? Were there problems acquiring those grammatical structures? Looking at how, again, functionally language is being used and or impaired in different contexts. Often for kids with language disorders, school becomes a really big component to consider because learning is based in language. And then as far as sort of the profession of speech language pathology as well, looking at standardized testing and measuring children's language scores based on what we would consider to be age-appropriate expectations. So in the field of speech language pathology, we talk about sort of 1.5 to 2 standard deviations below the mean would be scores at which we would start to become pretty concerned about language being impaired. And the further down you go, obviously, the more severe we would consider the language disorder to be. Other things to think of, and I think they're relevant for Fred, is that often there's a family history of language disorders, that it's a highly heritable condition. And I think Dr. Nicolson acknowledged earlier that Fred's mom has some definite language disorders, and her ability to convey her thoughts effectively and efficiently is not always what we would expect it to be. We know that those who have receptive impairments have a poorer prognosis overall than those who have only expressive components. And again, I think we've lost that in the new DSM to be able to kind of think about those as being different, but we'll talk about Fred and we'll see that he does in fact have impairments in both domains. And that, again, language disorders can occur by themselves and be the only thing that really is represented in the profile of the child or adolescent, or they can occur comorbidly with other conditions, things like autism. So for Fred, and again, Dr. Nicolson did a bit of history that I didn't know he was going to do, so that makes this slide a little bit less needed. But so he's an adolescent male. He does have a diagnosis of ASD. Interestingly, from a language perspective, he was raised in a bilingual family. So he's been exposed to one language at home, a second language in the community. I think now at home, his family uses English as their primary means of interacting, but I think they also use their other language as well. And he understands, according to his mom, and uses both languages equally well or equally as unwell, depending on how you want to look at that. But what we don't see is a difference between his first language and his second language. Not to my knowledge, he's only been tested in English. Yeah, so we're just going on parent report that he's the same in both.
What is the other language?
Arabic.
Arabic.
But that's, I mean, because I only know one Arabic-speaking speech and language pathologist in London. You know, well, he's not even in London.
I was going to say, I don't even know that I know one, because
Well, in this area.
to consider himself proficient in Arabic to assess in it, I'm not sure.
Right.
So,
I mean, that's a huge issue.
Yeah.
It's not just Arabic, but probably any other. How many people are not qualified?
Well, do we have the resources?
that's right.
Yeah, they've been
Arabic
translated
standardized.
appropriately.
Yeah. And so again, he's been known as speech language pathology services for a long time. So Dr. Nicolson presented some information earlier about his cognitive scores, and I just pulled these from 2 assessments that were completed with Fred, one in 2007 and one in 2017. And like Dr. Nicolson suggested, that his nonverbal skills, while they're not certainly strong compared to what we would expect for his age, in 2007, using the lighter, they were identified to fall around the 16th percentile, and in 2017, using the Tony for around the 10th percentile. And I think it's interesting too, in the 2017 testing, they also did some vocabulary testing, which really doesn't cover the whole scope of language, but you can even see there already the discrepancy between his nonverbal skills and his vocabulary skills, one being at the 10th percentile and the others being at the 0.1st percentile. Yeah.
Does not have like verbal IQ on him?
Nobody has done verbal IQ with him because of his language issues. It's been assumed to be not possible to do. And so that's why it was interesting the day he came to Dr. Nicholson's office and we pulled out again the WIPSI, which is intended for young children because he'd be the age actually of doing the WACE actually. Yeah, I know you presented him as a 15-year-old, but he'd be the age of a WACE. And we just knew that that would be far, far beyond his verbal abilities. But he did some of the questions, but with a fair bit of difficulty.
But I think one of the reasons is, in asking him to define a word, he may know what it means, but I don't know if he's be able to put the words together in terms of actually being able to define it in a way that would be meaningful. So ask him to define,
It's been a long time. She's retired.
So yeah, let's say, I think he knows what a horse is, but I don't think he'd be able to actually put his words together to define what a horse actually is.
But this PPT was the picture book had really grown.
Yeah.
Mhm.
So it would be more than just an expressive issue.
Yeah.
right?
Did you see on the previous slide that his writing has been tested?
No,
Has it been tested?
I don't think his written language has ever been assessed. No.
Does he ever use writing to try to communicate instead of using?
Nope.
unexpressive?
Not that that's an interesting question. No, not that I know of. We can certainly ask him to do that.
So Andy and I go over this a lot when we have kids that have documented low verbal IQs,
Mhm.
right? And then they end up scoring low also on their language or on their speech language testing. Is that an exclusion then? Because maybe their overall intelligence is not intellectual disability, but their verbal intelligence would be in that range. So do you?
Well, we have this conversation a lot. I mean, I think at the end of the day, life happens in language. And I think when language is impaired, regardless of what your nonverbal abilities are, you're going to have some pretty functional limitations in life. So I think functionally, he's a pretty impaired kid, regardless of saying his nonverbal IQ isn't within the intellectually disabled.
He
But
would be
I-
eligible for mental disability services.
Adult functioning.
Yes.
But I think that, so Joan and I have argued about this for many years, because Joan would say that nonverbal intelligence doesn't matter, or roughly, and I would say, well, then why do we measure it as part of an IQ test? And it's,
Because they don't have
right, but I think there's obviously a discrepancy between his verbal ability and his nonverbal ability on IQ test. So when you say is that an exclusionary criteria, what do you mean?
So like if we have a kid who scores in the first percentile
Yeah.
on language testing,
Yeah.
and he has an IQ of first percentile overall,
Yeah.
we typically don't give an additional language disorder. It's better explained by.
And that's what I think what DSM says, right? So I think it says
Yes.
language disorder, unless it's accounted for by something else. So it's in
But then when
DSM,
you have a kid who has a split, right, and strong nonverbal and a low verbal.
but I think that's what you see in people with language disorders, isn't it?
Yeah, I think
I think there's a lot of overlap too in terms of like you do a WISC and then you do some of the language measures that measure more that higher level type of language. There's a lot of overlap.
Yeah, because if you look at the WISC, right, there's a lot of language-based thinking as opposed to just core vocabulary and grammar, right? That it's more about sort of that higher level thinking with language as well. Yeah.
Because in the DSM-4, what it said for language disorder was that people's verbal IQ had to be their language scores had to be significantly less than their nonverbal intelligence. Whereas now it just has to be less than what would be expected for their age, which probably amounts to the same thing essentially. The problem is that people with sort of borderline intelligence, how do you include them? That's where it becomes a bit tricky.
So I actually think it's harder now because, again, if it's commensurate with their overall intellectual ability, it makes sense that you wouldn't call it a language disorder, right? But now they're using age as their defining criteria in the DSM-5, and that doesn't necessarily reflect then their cognitive profile.
But it also comes up in research. I know people who at Western do research in reading ability, and they don't tend to covary for intelligence, which I think if you have an IQ of 60 and you can't read, or you don't read well, I think that's very different from somebody with an IQ of 100. That's probably reading it, but they don't take that into account. And I think that's a huge problem personally.
I also think sometimes we do people a disservice by not doing the verbal IQ in this kind of scenario, because people look at the nonverbal IQ and call it their child intelligence, when in fact, probably are testable to some degree. And you could test them and give them a low score, and it would really better describe their overall function and than what, the system.
Yeah, that's a good point. Because this boy he's really profoundly disabled. I mean, he will never be able to work independently without somebody directly instructing him. And so I think you're right. The nonverbal intelligence probably is misleading.
And if you, I mean,
not a preferred measure, but in this case, a Stanford BA, the verbal portion of it doesn't always require expressive language to respond, even though it's
Yeah.
the verbal portion. So you can not as language loaded as
That's the with.
But with the receptive and expressive both being less than 0.1 centile, this kid has a lot of verbal output.
He has a lot of verbal output. Yeah,
So,
yeah,
And uses big words,
like Renopian.
like Pinocchio.
Yeah.
So it's, I don't think that would just be explained by, even if you were to diagnose him with a language disorder. it would
That's
not-
why we're here today. I literally, Joan.
We'll
and I
put you
have
in Camp Nicholson.
Yeah, Mandy and Joan
Yeah.
and I have been talking about this for probably 3-4 years about really what is it? Is it his language? Is it his thinking? Is it both? Because Joan would say, well, we think in words and therefore language represents thought. But which comes first?
No, but the connection from that part of the brain that is making him say the word is still connected.
Honestly, he strikes me as somebody who almost looks like what they used to call a fluent aphasia, right? People with strokes. Like he talks very fluently. He doesn't really stutter and things like that, but he just makes no sense.
That speaks for a more global dysfunction than just a specific one. It's not a language-based issue.
All right, well, you're kind of getting ahead of us here. All right, so again, to kind of highlight the impairments in language for Fred, in testing in 2005, actually his vocabulary at that point in time wasn't terrible. His receptive single word vocabulary was identified to be at the 22nd percentile. And so you asked earlier, so Hale, is it getting worse? It looks like it's getting worse. However, the expectations for vocabulary testing for this kiddo as a preschooler or an early primary grade student would be very different than the vocabulary expectations for him based on his chronological age. So much more concrete, associative-based label type words would have been expected in 2005, and certainly much more conceptually abstract type of words would be required at his chronological age that he is now. So in 2005, vocabulary was okay, but on the CEL-4, even then his expressive vocabulary was poor. And so it was identified at that point in time he had significant challenges, that he was best with sort of what we often say about these kiddos is sort of single key words. But as language became longer and increasingly complex, then his abilities deteriorated. The reassessment in 2010, at that point in time, we're really starting to see standardized scores, which I would consider to be quantifiably and substantially below what we would expect for his age. Standard scores of 50 and 47 with a mean of 100 on that test and a standard deviation of 15. And so again, the summary of that was a severe delay. And in 2013, again, what we were seeing was scores that put him far below what we would expect with a mean of 100 and a standard deviation of 15. And age equivalence from the protocol that we used at that point in time put him around a 3 to 4 year age equivalent level, which again, if he doesn't have an intellectual disability, why are his language skills at a preschool level? And I think even that may be a bit deceiving, because to say he's functioning like a 3-year-old, you tend to think about 3-year-olds having sort of short phrases and kind of about the key words, whereas Fred has long strings of dialogue as evidenced by the role play. And so in many ways, the age equivalent score of 3 years doesn't quite capture that qualitative component either of his language profile.
But at this point, if we were just seeing him for the first time,
Mhm.
without a lot of insight from psychosis lens, would we even be looking for this information?
Well, I meant,
Right.
I knew a teeny bit, but not a lot of background.
Right.
But what is remarkable is that he is quite unlike somebody who's psychotic. At the moment he came in, he introduced himself, he asked Dr. Nicolson to go shut the cabinet, like he was fairly socially appropriate the whole time. He focused on our questions, but except when he wanted to say his name, he was redirected. He did not present as somebody who was in psychosis or that, as somebody who's in a state of cabinet.
We didn't find his attention span was just not there.
No, I think he genuinely wanted to answer questions. So when he, like the question that I asked him, so Dr. Nicolson spoke, and like, the stories we asked him, school, how's your mom? And then when I asked him, I said, I said, just tell me a little bit, like, so, why do you see Dr. Nicolson? What did he do for you? You don't know the question for some reason. Dr. Nicolson did. But he actually, he's like, oh, Dr. Nicolson, he helped me wake up, wakey, like that. So he
please, let me clear, I'm calling the physician and surgeon in Ontario. I do not wake him up by saying wakey wakey in the morning, okay?
He was really quick in his mind. I think he had some awareness that I was asking about something to do with the relationship with Bob, and that maybe he was communicating that something, but I don't know what he was trying to communicate. But he listened to my question. He also, I went back to the question about grandmother's and we again tried to explain it in the phone, and grandma saying, "Oh, he was clearly trying to convey what he was thinking, and earnestly working to it just made it.
So apart from the way words come out of his mouth, I don't think there's anything else about him that suggests psychosis.
No.
Except for the words that come out of his mouth. So that's why I really wonder, what is he going to look like in 5 years?
If you're watching in the room with me,
Yeah.
I think we're having a typical, if the mute button was on and you were just watching them speak, you're having an average talk.
Right. Body language goes along
Yeah.
with.
He gets focused on freedom. They're teenagers rather focused on.
That was only when his mom was in the room with him.
Yeah, exactly. But that was it. If you looked at the interview with the mute button, you would think
And what's interesting too is
He also says, so I don't think there's any point that goes by where I don't find myself laughing. At another appointment, he was leaving with his mom, and as he was leaving, I said, "Oh, see you, say hi to your dad for me." And he looks at me and goes, "Which one?" His mother, the look on his mother's face was one of significant concern at that point in time. So, but you get the sense he's a fairly warm, friendly guy, actually. Yeah.
Really, you can describe him as warm and friendly. That is amazing.
he's
He is.
really likable.
Yep.
Yep, he's really likable.
And I'm not, and in that way, he almost, he has some characteristics that are not autistic.
Well, that's the thing.
Like,
Absolutely.
He doesn't fit that, like, he certainly doesn't come across in that way. Again, if you were to watch the video from the view on interacting with us, it would seem a fairly appropriate interaction.
So I pulled from the notes that I had some examples of phrases that he had produced during the appointments with Dr. Nicolson and myself. And so I think, you can just see from reading through those, again, I think you heard it nicely in the role play about how hard it was to follow the conversation. But there's examples here of, so I just did very good and try to be good. He's using words, and again, words are coming out of him, but they're words that are very imprecise. His vocabulary is far from specific and far from adequate to really know what it is that he's talking about. We're just baked it, or down in the bottom right, it was so good when Dr. Nicolson had asked, how are things at home? So we're seeing difficulties there reflected in verb tenses, in word choices. When I saw her for a long time ago, so prepositions and components of grammatical structures. When did you eat, or why did you eat spaghetti? Because it was so hungry. So again, pronouns. So I think in the examples that we can pull from watching him and listening to him, you're seeing lots of language type errors. There's vocabulary problems, there's grammatical problems, and then what will follow is therefore what comes of that as well is the discourse component.
First generation what?
Here in Canada. He was born here, I think.
For sure he was born here.
Mhm.
I don't know. I mean, they go back. They're from Egypt, I think, and they go back every few years.
First generation. There's.
I don't know if they are or not. To be honest, if he is or not. Whether it's his parents are from Egypt or whether they're their parents. I don't know. Yeah. She speaks without an accent, I would say.
Yeah.
Mhm.
But so I was just thinking though, Joan, if we go back to the question that you and I have debated about whether it's language or thought, I think the difficulty with the examples you gave, it's their single word or single sentence examples.
Yeah.
And I wonder if in testing that's what you really get more of is those single, and it doesn't really capture the flavor of his problems with communicating.
I think you're right, because in language testing, we're really looking at those core building blocks of vocabulary and grammatical structure, and he does quite poorly on those. And
How about a word
so-
salad?
So I would
Very
I would
much.
wonder if it's a sentence salad almost.
Yeah.
Almost.
Yeah.
But that's where there's no doubt he meets the criteria for a language disorder. What I worry about, is it something more, I don't want to use the word basic, but I
Is
wonder
it something else?
or-
Right?
or
Is
before
language
that.
Yeah.
Yeah.
Which again is why Dr. Richard kind of came in to weigh her. So
to provide the answer to the
to
question.
provide the answer. So when we told Sohail he was ahead of himself, this is your chance. Where do we put it all together? Yeah,
Am I on?
you're on.
Just one question. We haven't heard anything about that. Have we?
So it's a funny, because mom is a bit vague, a lot vague, which I know dad was living in Toronto for a while, and I don't know if they had separated or if he had moved there for work. And to be honest with you, because mom takes a while to get to the point, I don't always have the energy to ask. or the time. And I know, and Dad's living with the family now. I know that for sure. So I don't know what I've met him a couple of times, and there doesn't seem to be anything particularly unusual about him.
None of the siblings have.
There's only one sibling,
Yeah,
and she
sister-
seems to be doing fine.
Yeah.
So it was very interesting to me. I really enjoyed doing them. And I guess not kind of being in the background, but certainly seeing lots of people who have lots of work in what I do, which is episodes of psychosis where there's just integration of everything, language and behavior, thinking. It was interesting to see this color. So different. I mean, when I was reading about it, a couple of the thoughts I had, and Joan, you just said it, and I was actually going to bring that up, was do we have to think in language to have to organize thoughts? Would be my first question. And I would actually say no, like, so that if you look at kind of situations where can you have organized thought without it being language based, I mean, I would say that maybe like for kids who are pre-verbal, like say babies, right? Who it's clearly if you like at 6 months or 9 months, if you give them a food they like or don't like, they can show it to you. If you throw it or something like that, they don't have language, but they can clearly express a need or Rob's going to grow, but I'll give the example. I always have to bring up my dog somehow. A talk wouldn't be complete. So even when you look, I mean, you know, like I would argue that even in non-species that would be organized thoughts without it having language. So that is intriguing to me. That is language always a good proxy? I think in psychosis it is for a couple of reasons. Like I think what we see is that it's not only language that's disintegrated, but also everything else. So behaviors, other classic symptoms of psychosis that people have, whether that's like they get up and sit down 10 times they are very confused themselves in those moments. And so I think the qualitative difference from interviewing Fred to my patients is that when I have a thought disorder patient, they're clearly confused themselves. So they'll start off like if I say, you know, what brought you to the hospital? They may say, well, I don't know. I mean, I saw the red car, and you know, like what the FBI's like, but it was weird. Like they're clearly also confused by their inner experience. I didn't think Fred was. I think Fred knew exactly what he wanted to say. It just didn't come out in a way that we could receive it. But he didn't appear confused at all. He was contained, which again makes me wonder if his thought and language are uncovered, which is different than what we see in psychosis. So those are a couple of my thoughts. That I don't know that relationship is 100. It's always 100%, which makes me wonder if he actually has more structured thoughts than his language lets on.
And I guess if his behavior was more disorganized,
Yeah.
then that would suggest it's more thought.
Right.
But his language is disorganized at such a level that it seems, and this may be just lack of experience, but it just seems to me from other people we see with language disorders, I think Joan will say there's nothing remarkable about him, but I think that he seems very different from people with straightforward language problems.
I think the fluentness of his speech is partly what's remarkable about him. I think in more typical language disorders, we would really see kids with those halting sort of thinking and trying to get it out and not being able, whereas with Fred, it just flows from him, right?
But maybe that's because he doesn't know that he's not making sense.
Yeah.
Doesn't have that social awareness. But so Julie, if he did have psychosis, how would you know, do you think?
Well, I actually have a fellow who's very similar to him in language. He's not as chatty. He's someone actually, so he'll meet him a few months before he ended up with me. And he had a very similar, although it wasn't as chatty, he had a huge fluency called the really, he would only speak in approximations, but there was, the mom had actually brought him to neurology and then here to see Phil and then ended up in the PrEP program. And it was, what was different was that there was a clear deterioration that both at school and at home, he was fearful, angry, hiding in his room. Like there were other behaviors that told us that it wasn't just concern. So in my experience with psychosis and developmental populations, that it does happen, and I have to but you do see that deteriorative piece as well that clearly affects people. I mean, it's extremely rare even for high functioning people with psychosis to not have it. It almost happens. So for people who are lower functioning, they tend to impact even more. So that's what likely.
Can I read you a paragraph? Autistic children can be divided into two groups, those that develop better grammatical skills and those with grammatical deficits. And the autistic kids who have grammatical deficits depend a great deal on rote learning. And so if they, a boy, for example, who's afraid of the noise made by a popping balloon, would go boom, bang, what happens? The balloon exploded, the balloon was torn. So if you take a look at the language word salad, it could be from an autistic individual who has difficulty with grammatical concepts.
But I don't think his speech is delayed echolalia. I don't think it's rote learning. I think his speech is so disorganized that I would hope it's not rote learning, because if it is, he's learning speech from the wrong person. Because it's just that the words don't make, I mean, it's hard to imagine anybody else on the face of the earth using words in a sentence the way he does.
So they rely on television and other types of things, rather than from their parents. They pick it up from other sources.
Kathy wanted to say something too.
Yeah,
You, yep.
I just want to make I think it's an observation when I see deaf kids who are often really language delayed or language impoverished, their behavior is often disordered as well, but it's explainable because of their experience in language. So if their world seems chaotic, they impose order on a vibratory behavior. You can't get your needs crossed, you become aggressive because that's your form of communication. So those kids, after a lot of extensive investigation and a lot of time with them, it appears that their thought is not as disordered as the language. Their thought may be somewhat intact. There's just no way to express that. And it's expressed them through sort of behavior. And I'm wondering if this guy might be kind of the same. And they can sometimes appear profoundly functionally impaired. Now, the deaf kids have the difficulties with the incidental learning as well, but I think he's missed out on a lot of incidental learning as well as social learning. He hasn't been exposed to what we would say are typical learning modalities.
So what I think would be interesting is, I doubt he'll ever have children, but it would almost be really fascinating if he found somebody like himself and had a kid, see what that child is. It's sort of like I've read about, research into the hearing children of deaf parents and how they develop language. And things like that. It would be an interesting thing to see how his kids learn language and how much of it is exposure, or what is it that's going on with it. But certainly, I think, I think the point that Julie just made is a good one. That if it was a purely thought problem, although I'm still confident that I'm correct about this and Joan is not, that you'd expect his behavior to be more disorganized, and it's really not. I mean, he dressed himself, he showers, does all that kind of stuff appropriately as well.
And that's kind of my point. That his behavior is disordered from a typical perspective, but when you look at it from his context, perhaps it's not.
I don't even know if his behavior is disordered, as opposed to just the way his verbal behavior certainly is.
Are you talking, Kathy, more about his compulsions or
the
rigid behaviors?
Yeah.
Yeah.
That you mentioned earlier.
Yeah.
Yep. Okay, fair enough.
Yeah.
And then Sophia was going to say something.
So I think that, again, listening to it without seeing the individual, yes, there is deterioration in something. There is some level of disorganization that just doesn't fit anywhere else. So have we had any imaging of his brain, any?
So so he's had an EEG, it was normal. He has an MRI already. When I ordered first from the hospital, the radiologist wrote back and said, no, it doesn't warrant an MRI. Your CT scan is fine. So I spoke with Simon Levine, and he said to put down that Dr. Levine said he needs an MRI scan. And that's going to be done. It was actually all organized. And then he turned 18, and so we have to now move it up to University Hospital instead of a Children's Hospital. So it's supposed to be done sometime next year. I think when he saw neurology in the distant past, I think they did pretty much everything. And if you just look at the results of tests, there is nothing wrong with this kid, except for the genetic abnormality.
And then Claire was going to say something.
Oh, I was going to ask him, sorry if I missed it. Was this early trajectory one?
Yes.
In what sense?
He was diagnosed at.
Yeah. But and he was diagnosed at 6, and this was in 2005 or so. That's when I think that was a reasonable age to diagnose people with autism. And he had seen speech and language people before that. And just looking back this afternoon, I was looking at our casebook on him. And I think even in grade 1, they were commenting upon his delayed echolalia and the fact that he referred to himself as he and things like that. So his language has always had problems at some level.
Like you described him as a warm individual.
He's always had problems.
Even if the content.
He's always had problems getting along with peers when they say that he would always try to interact with people. but because he was adamant, people would greet him when he said hello, and he would walk into the boys' washroom, want everybody to give him high fives, which, having been a teenage boy once, I don't know if I would actually want to engage in that kind of behavior for a variety of
So
reasons.
he has some superficial
Yes.
social
Yeah.
skills, but I'm not sure that they're really all that.
No, but
great.
I think you don't get the sense of that disconnectedness when you sit down and talk, the way you do with a person with classic autism.
Not the way you do with classic autism. However, it's interesting because I think he's much more engaged with you than he is with me. He really doesn't give me the time of day in the appointments. And I've been in several of the most recent appointments. And yet I don't get much acknowledgement other than he did go around and greet each of us with a handshake and a hello when he first came into the appointment. But none of his conversation is directed toward anyone else. It is directed towards you. So again, in a really superficial way, it looks good.
Well, you know, Dr. Nicolson.
Well, you know, Dr. Nicolson.
Every third sentence has Dr. Nicolson at the end of it.
And he does have really autistic type intonation. So it's kind of that harsh and stilted. And so, you know, his speech, it flows, but it does have kind of a funny sound about it as well.
So, part of my reason for asking is the language is reminiscent to me of many of the alcohol. They're very verbal and early language in terms of vocabulary, number of words in a sentence, and so on. But as they get older, the deficits start to show in those higher components of language, and they talk a lot.
So,
They're very social, but they have a lot of social problems, and their content is a little better organized than what you described. I have a bunch of here. And some of them, and the other thing that's reminiscent is when other people in my patients they think maybe psychosis because they start talking about things that haven't happened or elaborating on things, but it's different. So if they have a psychosis, no, they're letting it on that.
And that's why I collected them, because they come to us for diagnostic, they go. So the difference is that they can tabulate. So not unlike with dementia, you can understand their story perfectly, but they make it up. Exactly. But there's no problem understanding their stories, but they're just fantastical. They don't make sense.
but so with him, I don't know if I ever asked his mom about alcohol when I first met him, but and I don't want to, I guess, give away my middle-class white male values. His mother certainly doesn't seem like the kind of person who would drink a lot of alcohol at any point in time, let alone when she was pregnant. And there's no other evidence to suggest it.
So,
But it's interesting.
Yep.
Yep. Well, and
At
that's
this point, I'm not sure how but
well, I mean, it does have this deletion on 7q, which is sort of a variant of uncertain significance, but I guess it's uncertain because we don't know. Maybe if we will. But you know, so when you were saying though that there's clear deterioration, I mean, are his language scores actually deteriorating? Because they've gone down, but are they approximately the same over the last 5 years?
I think the only thing that really looks like it's deteriorated is a single word vocabulary, but I think that's changed because of chronological age-based expectations changing.
So if you just look at his raw scores, have they changed? That'd be the real question.
Yeah, I don't know, and I don't have that with me, but.
And I'm honestly saying, I don't know his overall. I looked at his Vineland scores. I don't know how much they've actually changed. I think it's more that the difference is becoming much more apparent. So if we look at the raw scores, not the scaled scores and things, I don't know if they've actually changed. They certainly haven't increased the way we would have expected them to. And so I think because of that, the gap has widened.
That in itself.
But there's nothing else suggest. I mean, that's the question though. I've always got. You know, what is he going to look like in a few years? There's nothing. He doesn't walk around talking to himself or listening. Like he doesn't look like he's hearing voices. There's no evidence that he thinks other people are out to get him or afraid of him or things like that. So there's no evidence of positive. But that's sort of what I was wondering. You know, what's he going to look like in a few years? But how would you even know at the end of the week? I think you'd have to see marked deterioration. I think how he interacts with people, I don't think that's really changed much over the years. At all. I think his social interactions remain.
The only time to change is with that.
The one time when he was just not himself at all, he was just mumbling, and you know, and if that had carried on for a period of time, then it wouldn't.